Good morning, everyone. I've got a very special privilege of opening this session as a sponsor of this session by Anglo American, and particularly because women's health for us, and for me particularly, is such an important issue. I came down here expecting to see this room bursting at the seams with no space, standing room only, and sadly, that's not what we've got, and I'm afraid that's how it usually is when we get to talking about women's health issues. And that's something that we've got to change. And the reason I'm able to talk so confidently about it now is because I have the privilege of having chaired a women's health organization, the International Women's Health Coalition, based here in New York for the past several years. And I've had a marvelous opportunity to learn from women working in the field and to better understand the issues and to understand the neglect of the entire world for women's health issues. Well, at least in business, there is an opportunity for us to make the changes. And if in businesses we can make the changes, maybe that then can permeate out into the greater society. And particularly when it comes to women's health issues, the one that nobody really wants to get down to talk about is when you talk about sexual and reproductive rights and health. And the one thing I've been taught is that the rights come before the health. Without the women's rights, there's going to be no women's health. And I've had personal experience of it in dealing with HIV and AIDS. And I'll give you a shocking statistic from South Africa. By the age of 21, 20% of our young girls are HIV positive. That's shocking. But what's even more shocking is that the boys of the same age, it's only 5%. And you have to ask yourself the question, what's going on here? Why the difference? And the simple explanation is that young girls are being systematically abused and exploited and denied access to the care and the help that they need and the understanding of their rights and the respect for their rights. It's a shocking state of affairs, and we really do have to work hard to change it. We as a company are really committed. We had a female CEO for the last 7 years, and wow, that made a big difference. And it was great working, and I hope we can, in the corporate world, see much more of that. But there are a lot of experts here who are going to tell you of some of the really successful stuff that's happening. And so Naomi, where are you? Behind me here. You're going to moderate the session, and I hope you're all really going to enjoy it and then spread the word when you've heard it all. Thank you.
Thank you, Dr. Brink, and good morning, ladies and gentlemen, and thank you for coming to this fantastic session this morning. But before we start, the panelists and I would respectfully request that you join us for a moment of silence to express our condolences to the people of Bangladesh, mourning the loss of at least 1,127 people in the recent Dhaka factory collapse. Each and every one of us can and must commit as a consumer or as a professional to improving the working and living conditions of workers around the world. What can you and your company do to help? Thank you, everybody. So, healthier women means stronger societies and stronger economies. Investing in women's health means investing in social development and economic development, both in the present and also for future generations. But not only does women's health impact on a societal level, it also impacts at a business level. Investing in women's health is good for your business's bottom line. Women today make up a greater share of the workforce than ever before in history. And the workplace is often ideally suited to a wide range of health interventions. The convenience of being able to access health services at work has been shown to be a critical factor in increasing service uptake. And the support that can be provided by groups of peers, achieving common goals, or forming a unified stance on issues such as reproductive rights and family planning can be crucial in challenging accepted norms. By meeting the contraceptive need of one woman, your program, through this one service, can allow a worker to make her own reproductive choices, support her family and continue to provide support for her family, reduce their need for support from society, and retain her skills within your workforce. As Her Excellency Dr. Kaseba-Sata said yesterday, family planning helps to break the cycle of poverty. But as we've heard, it doesn't stop there. Workplaces can also be the setting for a wide range of women's health interventions: cervical and breast cancer screening, HPV vaccinations, HIV services for women and men preventing mother-to-child transmission, TB programs reaching people who do not otherwise readily seek out care, and programs addressing gender-based violence by engaging women, men, and youth in changing the perception of gender norms. And if any of you are sitting there thinking, this doesn't really apply to me, we've got a male-dominated workforce in our sector, and perhaps you're thinking of nipping out for a quick coffee or, wandering off, please don't, because engaging men is absolutely critical to many women's health issues. And the business case still adds up, even in male-dominated workplaces. For the last year, I've had the privilege of working with Joya Banerjee at GBCHealth and Alan Smofsky of Smofsky Strategic Planning on a study focusing on workplace wellness initiatives in low and middle-income countries. The report is available on your tables and also on the materials desks. I was told to wave it ferociously. The materials desk near reception. And many of you here took part in the study, and on behalf of all the authors, I'd really like to thank you very much for your efforts, your energy, and your participation. We surveyed 40 programs in 31 different low and middle-income countries around the world, operating in a variety of workplace settings and in different sectors, including services, manufacturing, and extractives, and in non-profit organizations. The survey allowed us to characterize some features in common: structural and management characteristics of the programs, the organizational motivations behind the programs, the nature of the health targets and the health risks that were targeted, and how interventions are delivered, and also the challenges that program managers are facing on a daily basis in implementing effective programs. The report describes how we've really mapped a picture of evolution in workplace wellness. Many start with an HIV focus, not exclusively, but an HIV focus is fairly frequently found. And then there's a demand from the participants for information on a broader range of topics: sexual health, STDs, family planning, relationships. From the discussion surrounding stigma and discrimination related to HIV, broader topics around mental health and mental well-being emerge. The natural flow then turns to the physical determinants of well-being and onto healthy lifestyles and non-communicable diseases. Programs also evolve on a second axis, from purely information delivery platforms through to providing active interventions for prevention of illness, and then also screening services and ultimately treatment services. When we asked our participants about how their programs were delivered, our respondents universally agreed that their peer educator networks were critical to understanding their target populations, starting a dialogue, and designing effective and culturally appropriate interventions according to the need of the populations in which they're set. We all know that making the business case is critical to program sustainability. However, we found in our survey that there wasn't a clear demonstration of a link between the health targets that were selected and the business cases being made. for the majority of programs, by no means all. We believe that program custodians would benefit a great deal from support in several areas, particularly a detailed assessment of the main health issues impacting the workers, and also a detailed analysis or careful analysis of which key performance metrics reflect the impact of these health issues, and they can then subsequently be used to measure the success of the program. Making a clear case, linking the steps from intervention to improved health to achieved business goals will assist with securing senior leadership buy-in and ongoing support. To date, we're very fortunate to have 3 experts to address these issues and share their experiences with us. Firstly, I'm pleased to introduce David Wofford. David is the Vice President of Meridian Group International in Washington, D.C., where he manages the USAID-funded Raise Health initiative for workers, companies, and communities. Next to David is Rachel Myers. Rachel leads her project, BSR's Global Women's Empowerment Initiative, that creates workplace programs through partnerships with multinational companies, factories, and local NGOs. Rachel oversees more than 150 global programs promoting women's health and economic empowerment in factories and farms across Asia and Africa. Finally, may I introduce Dr. Zafar Ullah. Zafar is a pioneer in developing a sustainable public-private partnership model for the National TB Control Programme in Bangladesh. He is the Deputy Head of Research at the Leeds Institute of Health Sciences at the University of Leeds in England, and also the CEO of a Bangladesh-based NGO called SEED, which works closely in collaboration with the National TB Control Programme, WHO, and the Bangladesh Garment Manufacturers and Exporters Association. So now we're going to hear from each panelist in turn, and then there'll be the opportunity for questions from the floor after that. Please also submit your questions via text. I don't know whether we can display the text number, that would be helpful. And they'll magically appear on an iPad somewhere. And thanks to HP for their fantastic technology. There it is. So, over to David. Thank you very much.
Thank you very much. I'm going to talk about the full business case for women's health, and both from the corporate headquarters to the factory and the farm. And when I talk about it in terms of the full business case, just to give you a little context about Meridian, it's not the Meridian you know in Washington, it's the other Meridian. We're a women-owned business based in DC, and for the last 10 years we've done a lot of work around business and women's health. I manage the Raise Health initiative, and we're focused on elevating worker and women's health issues in the policy and program development discussions around sustainability, CSR, corporate social responsibility, human rights, labor rights. And we're funded through USAID through a USAID project called Evidence to Action, which is managed by Pathfinder International. So Raise Health is about finding cost-effective ways to embed health, worker health, women's health into the DNA of companies, business systems, and global supply chains. And we've done a lot of work around the business case for women's health, and I want to talk about women's health in at least 3 ways. First is financial ROI, and this is one everyone talks about. It's about money, why you should do it, what your return is. The second one, I want to talk about sunk costs. This is overlooked often. There are a lot of fixed costs already done, and are you getting enough out of it? And the third is one I just made up. It's called the opportunity ROI, and it's really about the area I think is most interesting is what can be done to do far more around health. And this is what I consider the full case for business for women's health. Too often, as we've discussed here, women's health is treated as an add-on to all these discussions about CSR and empowerment and worker rights and development. And in fact, women's health is an essential component of all these issues. And by women's health, obviously we're talking about reproductive health and family planning, but it's a wider range of issues, from nutrition and hygiene, menstrual hygiene, maternal health, protections against sexual abuse and harassment. So we can see that women's health is really about the health of family and entire communities. By financial return, of course, we are talking about improved productivity, and the typical way of looking at this is absenteeism and turnover. but also better quality, less errors, and there's a range of indicators. The first thing I would say around this is that I think the case for financial return on investment is actually quite strong. And I actually think it's one of the self-evident truths that we keep trying to prove over and over again. But let me first start very briefly and do a quick look at the macro level and then go into a couple of very specific case studies. First, going the wrong way. First, Harvard 2003 study looking at health and economic development saw statistically significant positive returns. Then the annual Global Gender Gap Index done by the World Economic Forum, and we see that there is a strong relationship between, I want to go back here, sorry, clicked too fast, between gender gap and economic competitiveness. And the World Bank has plenty of data talking about women's participation in the economy and in a country's GDP. If both are low, they're related. And now just most recently, UN Foundation did their own study on the ROI for investments in family planning and development. So I think at the macro level, it's very clear. But the fact is, women's ability to participate fully in a country's economy requires addressing women's health and family planning. Women who are unable to plan and space their children, face abuse and harassment, have limited capacity on a range of health issues, general hygiene, menstrual hygiene, are much less able to join the workforce, stay in the workforce, and be productive. So with that context, let me look at a few examples that Meridian was directly involved with at the workplace level. And to go to the country that's much in the news for very bad reasons, let me talk about a quick intervention we did with partners. In a 450-person factory, 85% women, we did a half-day set of, we provided a nurse and doctor to provide full comprehensive services, including family planning at this factory, and we saw decreased absenteeism, turnover, better morale, and other benefits. Then, several years later, in 2009-10, with her project in Egypt, with the partners, we did similar interventions, and Rachel will talk far more about their approach, but same thing, drop in turnover and absenteeism, and improved morale, and lots of other benefits. And let me say, these were not controlled studies, but we were able to compare the men in the blue line to the women, and with qualitative data, we think there's very strong evidence of the relationship between women's health and productivity. So, moving on. Let me talk about why this is. Well, you see the health risks. There are numerous health risks, and these have direct relationships to business impacts. And when we look at Bangladesh and Egypt, somewhere on the order of, we estimate, $3 or $4 return for every $1 invested. Now, this isn't a hard number that everywhere you're going to do this. Every country context is going to be different. But the point is there's baseline evidence that there's various levels of return for making these investments. So, next, sunk costs. And I think, let me say something before I talk about sunk costs. I know that there are many excellent workplace and programs and health services provided by companies, and so this is not to say those aren't excellent, but I do want to say that many of that my comments will be broadly true, and even some of them may be applicable to even those excellent programs. And the main point I want to say is many of these investments are underused, and I could argue that they're wasted resources. So let's look at where that we see resources spent. There's a lot of money put into TB, HIV, tuberculosis, other diseases. These are very important programs. And the things I want to say about this is, first of all, if you're not including family planning, we just have to be honest here. You are not getting the most out of your investment. That's a fact. Women's involvement in these and their reproductive health issues are fundamental, and if you don't deal with family planning, you're not fully addressing those diseases, no matter what you say. And we have to say, and that represents an underused investment. And if you don't believe me, go to Core Group report, Better Together, which documents the value added of family planning to all these diseases. And they make the case that if you're not doing family planning, you're actually not getting the most out of that investment. So I just want to put that on the table because we have to say that strongly. Second of all, just in closing, I think we all see a lot of 2-year, 3-year kinds of programs that aren't embedded in systems of suppliers or companies, and after they're done, yes, they did some good things, but they have no staying power. I would argue that is a lost investment and a wasted investment. So I'm going to go very quickly because we have very little time. Many health staff in clinics around the world are underutilized. Nurses and health workers give out Band-Aids, they give aspirin, they send people home or to the hospital. Their focus is on curative care, and either their talents are underused, but there's little investment in improving their capacity to do more, and it's a sunk resource. Same thing with health clinics. Workplace health clinics are usually the last place management in factories and farms look at for improved productivity and results. And this is a fixed cost. And I would say that improving the quality beyond just occupational health issues can have significant impact at limited cost, looking at quality improvement and other issues. So why the poor return on these fixed costs? Well, I think the fundamental fact is that this is not an area of management skill or focus. Health is disconnected from operations very often. It's seen as an add-on cost. And it's also disconnected from public health services in many cases. Yes, there are many exceptions, but as a broad statement, that's true. And this leads me to the area that I think is the most interesting, which has to do with the opportunity ROI. And the thing to say is I think this is an area for innovation. Thank you. Doing more with existing resources, looking at health from a business systems perspective, recognizing a range of broader returns, and getting more from your investment. I'll talk about 2 Raise Health programs that I'm really excited about. One is we're looking at how to do workplace baseline voluntary standards for clinics. We're doing it in partnership with BSR and Better Work, and in 6 or 7 months we'll have more to say about this. But this is to really raise the level of standards in factory and farm workplace clinics. Second of all, health providers. We're in Haiti, and there's a factory that's very interested in re-engineering their clinics to be more proactive, tied into management functions and productivity. More on that in about 6 or 8 months. Second of all, just say all of this is about taking a business systems perspective. We can look at all the things, and I just do a plug for BSR. The way they've evolved their program around this is fantastic, and much of what Rachel will say, I think, will have elements of this. Finally, an area that I think, in my 1 minute left, is I want to talk about broader returns and a way to think about ROI in a very different way. I cite John Kay, an economist who wrote a book called Obliquity, and his main case is in complex issues like health and behavior change that our goals are best achieved obliquely. And I think women's health really fits into this. Our workplace programs did meet our goals very often around health issues, but they also had a range of other kinds of benefits, from problem-solving skills, leadership development, professional development, empowerment. These are all real business issues that can be dealt with obliquely, but actually are critical to the business case for health. This is a picture of a woman who not only became a leader in the Egypt factory in health, but then went into her community and did remarkable work in her community after her project. So, to close, I do want to say something about men's engagement. BSR, GBCHealth had a big job in this Healthy Images of Manhood. This is a Unilever employer taking his son to a health clinic. Yes, we got to change health behaviors of men in this workplace program, but you can see it also changed the gender equitable assignment of jobs. That's a huge business issue on how to use your workforce fairly and more equitably. So to close, the bottom line for me is, yes, when you factor in the hard financial ROI, the sunk costs, the broader returns, the oblique returns, women's health is not just cost savers and game changers, but also they are not just cost producers, but they're game changers. So I want to thank you. Sorry for going quickly, but I'll be happy to answer any questions.
Thank you very much. Now, Rachel's going to speak with some more case studies of some successful programs she's been involved with.
Yes, and I should say that I wish I could take David with me everywhere I go. I sort of do, but he's such a good opening for the work that we do, and we've had such a long and fruitful collaboration. So just to introduce myself again, my name's Rachel Myers, and I work for an organization called BSR. It's a little bit like GBC. It's a global membership organization that works with business on social and environmental sustainability issues. So we're covering kind of the gamut, and we work with industries all over the world on all sorts of different challenges. Her project is a program that we created about 6 years ago to really address this issue of women migrating from rural villages into urban areas to take jobs in factories and in farms, and really trying to understand the vulnerabilities that they might face in taking those jobs. So I'm going to talk a little bit about the work that we do and some of the impacts we've had and seen, and some of the resources that we've created that hopefully some of you can find useful to beginning to support women's health more effectively in your workplaces. So the mission of her project is to empower low-income women workers through workplace programs that promote general and reproductive health. We also work in a couple of other areas, but obviously, given that we're at GBC Health, I'm going to primarily focus on the health work that we do. So we began the program with 10,000 workers in China in 2007. Today, we're working with more than 200,000 women in 8 countries around the world. We work in mostly in Asia. We cover all of South Asia, Bangladesh, India, and Pakistan. We work in China, Vietnam, and Indonesia. And we are working in Egypt and Kenya as well, and hoping to expand further within East Africa in the coming year. We work with a number of different company partners. So we have 22. I think we're signing on several more in the coming month, so that number is going to have to change. But we work with leaders in the industries, in garment industries, in food retailing industries, as well as in clothing retailers, footwear, electronics. So we run a full gamut of different industries. Our methodology, I can talk a little bit more about it afterwards, or if people have specific questions, but fundamentally it's a peer education methodology. We work with women who are factory workers. We train them to become health educators and activists among their colleagues in the workplace. And our program lasts for a full year, and we cover different topics on a rotating monthly basis in order to really cultivate the information among the women so that they can feel empowered to share it with others. And our main objective is demand generation. We want to provide the information on correct behavior and healthier actions and preventative actions to be taken towards your health. And so we're really trying to generate demand for services that are provided in the workplace, but more so in the community. So we've seen a lot of different impacts around the world. I'll highlight Bangladesh. I know Zafar is going to talk even more about Bangladesh. It seems to be the country of choice at the moment. I like telling positive stories about Bangladesh. It's one of my favorite things to do. So we are working, our program is very holistic. We cover hygiene, nutrition, and then we cover issues like family planning and HIV/AIDS, STIs, safe sex, waterborne diseases, insect-borne diseases. So we really cover all of the things that a woman might be concerned about in a country like Bangladesh. We've seen amazing impacts from our programs in Bangladesh, from access to services, managing menstruation. I have a bit more data on this. And nutrition, really encouraging women that, on their salary, they can afford to eat protein and get iron into their diet and get vitamin A into their diet. So really battling against basic misconceptions that are pervasive in the communities that we work with. In Egypt, David spoke a bit about the financial ROI that we saw there. We also saw really impressive impacts on some of the health issues. Hand washing, I think, is really interesting. There were huge changes there. There were huge changes in terms of opinions on family planning. Hepatitis C, and elsewhere in the world we see hepatitis B as being really, really misunderstood or not understood at all. because very few programs really lead to those, really focus on those diseases. And I think this is really telling that 82% of the workforce said that they took action to improve their health as a result of what they learned. So I think that's sort of our ultimate goal, is to really empower women to make better choices for themselves. This is just a quote from a woman named Fatima, who's a Her Project peer educator in Bangladesh, talking about something just so basic as eating regularly during the day and eating the right kinds of foods. And then also, I think, really wonderfully, her feeling like she could teach her daughter and improve her daughter's circumstances as well. So I won't go into any repetition of what David said, but I think we have also seen really tremendous business benefits, from the most quantitative to the most intangible. So I think on the direct benefit side, David talked a lot about this: reduced absenteeism, reduced attrition rates, and improved preventative care of the workforce. I think some of the indirect benefits, one of the ones that I'll highlight the most is really the improved communication between the workforce and their management, where there was almost no communication before about personal issues or workplace issues, and rather just kind of a yelling and obeying relationship. You see some actual back and forth relationship developing around this kind of issue that affects all of us, which is our health. In Bangladesh, I think menstruation is an issue that isn't particularly comfortable to talk about, but that I hope a lot more people will start talking about. We see, you see right here, 75% of women that we work with in Bangladesh said they were missing up to 6 days per month, because they got their period and they were scared to go to work, or didn't feel they should, or didn't know how to go to work and manage that very basic health issue. And so we really work on improving uptake of sanitary napkins, of improving basic hygiene practices if sanitary napkins aren't available for purchase or you're not comfortable buying them. So that's been a real focus of our work there. And related to this, I think a lot of the cost savings that we saw in Egypt was related to menstrual leave reduction. So I think this is an issue that's incredibly simple, it's incredibly low cost, and it's probably affecting 99% of the women in your global workforce. So start paying attention to it if you aren't already. I wanted to share some resources that we've developed. As David referred to, we are really conscious of the fact that we can't reach every factory in the world or every farm in the world, nor do we want to. The business case is there, so your businesses should be taking some of these things on yourselves. Your healthcare workers, your human resources department, they should be addressing some of these issues that are not being addressed in schools yet in these countries. So we've been developing best practice resources based on our programs, developing them in partnership with global health leaders as well as the local organizations that we work with. We've developed a 12-module curriculum that's designed for delivery in the workplace. They're all 1-hour modules. They're built for people who aren't trainers to be able to deliver basic trainings. And we're translating them into Chinese, Bengali, and Arabic, and they should be up on our website soon in those other languages. But right now they're there in English, they're free. Please use them and share them with your colleagues in different countries around the world. That's just an example of what the family planning page looks like on the website. You can see we have a training guide, we have a more in-depth manual, we have activities, and we have a post-training quiz. The other resource is something we've developed called the Her Project Tool Builder, which is a tool for building low literacy health training materials that can be printed and used in the workplace or in the community. We're actually launching this publicly at Women Deliver conference in Malaysia in 2 weeks. We've been using it with our partners for the last 2 years, but we want to bring it out into the public good because we think the availability of really good image resources is lacking for a lot of the smaller NGOs, and certainly for the private sector. And David mentioned the health clinic upgrading standards that we're working on in partnership with them. We're also going to be coming out with a study looking at women's health needs in Ethiopia, Uganda, Rwanda, and Ghana in a couple of months. We've been doing some research out there. So I'll just close in saying I think there's a few things that I've learned working on this program over the last 6 years and that I'd really like to impress upon business about gender and about women's health. I think the first piece is that gender matters tremendously, and too many of our, the other hat that I wear at BSR, I work a lot on supply chain issues, compliance, and too many of our compliance documents, our legal documents, the way in which we monitor good behavior in our operations and in our suppliers, it's gender neutral. And what gender neutral means in countries like Bangladesh and Kenya is that women get left out and that their issues aren't raised. So you can't be gender neutral in any of your business management documents as you grow your business in the developing world. The second thing is that jobs are empowering in and of themselves. Even the tragedy in Bangladesh is very, very upsetting, but for those 1,100 people who lost their lives, 2 million others are employed every day in that industry who never had access to wages before. So creating jobs is incredibly important, and making sure that you're creating jobs that women can access is incredibly important. And then finally, it's the theme of our panel that women face unique challenges, chief among them their health. Financial literacy is very en vogue right now. We're working in that area too, but don't forget women's health. It's got to be at the center of everything that you do related to gender. Thank you.
Thank you very much, Rachel. Now, Dr. Zafar Ullah is going to talk about his TB program in the garment factories in Bangladesh.
Good morning, everyone. First of all, I'd like to thank GBCHealth and particularly Joya and her team to giving me the opportunity to speak on behalf of the tens of thousands of women in Bangladesh who are working in the garment sector. And while talking about the wellness of those poor, vulnerable women, those who are working in the garments factories in Bangladesh, there is an obvious question to all of us, to the businesses, to the community, that how can we make the health services possible or bring to the doorstep of their workplace or where it is best suited for them. So we are talking about their health rights. Of course, we can empower them, we can inform them, but then how to provide, how to make these health services available for them, nearer to them where they are working. So that's the question we had at the beginning of our project. SEED, the Society for Empowerment, Education and Development, a Bangladeshi NGO, who has been pioneering to develop public-private partnerships model, taking different health programs as an example. So we started with TB program and involving the private sector within the national TB control program, but then we expanded or adapted the same model to family planning, sexually transmitted infections as well. So we started developing the relationship or talking with the business sector, particularly through the Garments Manufacturing Association, that how can we then bring the TB services for their workers. So we developed this partnership model with the 60 garments factories in Dhaka areas, and we found that the partnership model worked, and it worked to help to detect TB cases, and many of them are women, and we'll talk more about that. So looking at the broader context in Bangladesh, particularly around women, Bangladesh is a densely populated country, having 150 million people within 55,000 square kilometer space. It's a poor country. Looking at the GDP is less than $500 per capita. where garment factory is the major contributor to the economy. So garments industry is very important in the context of economy in Bangladesh. But looking at the overall the situation of women in Bangladesh, they are both socially, economically subordinate. They have low status, and they are, therefore they are vulnerable in many ways. And if we are talking about health and health services, they are even most disadvantageous of all. If we look at the TB as a whole, I mean, it's a killer disease for many countries, many developing countries, and Bangladesh is not the exception for that. If we look at two indicators, then probably you'll recognize the magnitude of the problem. There are 300,000 new cases every year in Bangladesh, and more than 65,000 dying of TB every year. So if we look at this, I mean, we can imagine the size of the problem. What are the specific issues, TB issues around the workplace then? First of all, we found that there are lack of awareness amongst both workers and the management, the factory owners, about the TB management, the TB symptoms, and most importantly, the availability of TB services nearby. So they didn't know from where they can get the service about TB if they want to. There are also inadequate knowledge of the medical staff, and we'll talk more about the availability of medical or health facilities within the workplace. And I mean, most of the medical personnel, those who are available or appointed, had very limited knowledge about TB management. And I mean, we asked them about a TB case, a standard TB case, and we got 7 different prescriptions from the doctors. From the worker sides, there are stigma and discrimination not only around TB, but as a whole, and that compels them to hide the diseases. So even if they suspect that they might have TB, they hide it because they think that if the manager or if the co-workers, they know it, then probably there will be problems. So they keep on hiding the diseases, and then that creates even more problem, both in terms of suffering from TB, but also transmitting TB to others. There are also very long working hours. I mean, if probably Rachel would know more, that they start at 8 o'clock and finish at 8 o'clock, 9 o'clock at night with only 1 hour lunch time. So there is no time to go for health services anywhere outside of the factory. So there's another problem we have. And that's why there are a lot of discontinuation rate of TB amongst the workers. This is one of the statement which we got before our project, and I mean, they usually have a dilemma what to do when they know that there is a TB case of sitting somewhere nearby. What we did, we embedded the program with the National TB Control Program because we thought that they are the service provider and they do have the free diagnostic and TB drugs. So we partnered with the national program, but we also involved the Garments Manufacturers and Exporters Association, BGMEA, who are the political apex body for the all garments factories. We piloted this project in 60 garments factories involving around 70,000 workers. So we mapped all the garments, and we found that there are 3 categories or 3 types of factories depending on the type of medical facilities available. And we grouped them into 3, like category A, B, C, but you can say anything else. So one category, those who have got medical facilities, I mean doctors and paramedic and a small health corner within the factory. There are factories where there is only a paramedic or a sort of sub-medical officer, and there are at least a third of factories we found that there were no medical facilities, although they, in theory or in paper, they claim that we have everything. So we then connected them with the existing health services. So I'm not going into the details of this picture, but the arrow shows the linkage between the factories and the existing TV services. So where there are doctors, they can go only for the lab test. Where there are no doctors, they can go for both lab tests, and if they are positive, then they can go for diagnostic and treatment. But they can also go to self-referral to the private practitioners whom we trained. We also sensitized the owners, the managers, workers. We used their own PA system, which they have within the factory to listen to the music. So we used our TV messages through those existing PA services. We developed different materials, particularly the desk materials for the medical personnel, but also different information leaflet for the workers as well. What we achieved, if you look at the, I have just quoted one particular statistics here. We examined more than 3,000 workers for TB, and we found around 600 of them are positive. And out of 600, 145 of them were treated in the factory at their workplace. So they were diagnosed, treated, and maintained the 6 months treatment regime within the factory. And what we got is the 100% cure rate of all those 145 cases. So that's another business case that we need to provide the health services at the workplace. Look at the rest, 453 whom we referred to the NGO clinics. They were treated, but if you look at the success rate, it was less than 100%. It was around 90%. We also then changed the behavior and attitude of the government's managers. Now they give paid leave, so they don't fire those who have got TB. They also give time off during their working hours so that they can go for TB treatment. But also, from the policy-making side, we advocated the national program to include this model within the national guideline. So what we have learned? We have learned that this model works, as simple as that. So what is our next thing to do is to take this, adapt it, and scale up in other government's factories. But in order to do that, we need your help. We need all the businesses to take this model or take this type of model, adapt it based on the situation you have or in other factories, and scale it up and provide services for the workers. But we also then, we have got principles or the best practices, experience from this project to make or to develop a sustainable solution for the other health programs or other health problems of the workers. Finally, I would finish with the quote from a worker, cured TB patient called Bina in one of our partner garments factories. Now, my manager gave me 15 days paid leave, allowed me to join the factory again. I'm also getting time off for TB drugs, and that helped me to save 4,000 taka, which is equivalent to $50 for TB care, and I'm better now. So we are working for them. I'm happy to take questions now or after the session if you have. Thank you.
Thank you very much, Zafar. So it's time to open up to questions from the floor. You may want to ask David about issues surrounding return on investment and the broader business case for workplace wellness programs focused on women's health issues. You may want to tap into Rachel's expertise on peer-educated delivery models and the pros and cons of those, how to go about selecting interventions that are really effective in the workplace. And you may want to ask Zafar about the lessons he's learnt and how he's been successful in forging extensive multi-agency and public-private partnerships and collaborations and getting those to be effective. So are there any questions coming in? Gentleman at the back there. Yep.
Thank you. My name is Daniel. I work for Swedish Workplace HIV/AIDS program. And I wish to commend both programs, the HER and also the health images of manhood, because it's something I know back in Kenya. And I know we borrowed some concept in it, integrated with peer education. My question is on the HER project. I was wondering, at what point did you engage men, or it was purely for women? Because when it comes to family planning, for example, it's not just a case of one partner, but you have also to include the other partner. Then in the same breath, and these workplaces, I've seen that one of your results was good collaboration between workers and management. Did you work with the unions? How did you engage these workplaces? Unlike in Bangladesh, where they are government-driven, did they have policies to do with their work culture so that there is no sexual exploitation, and that these women can also be allowed like flexibility when it comes to accessing these services? Thank you.
Talk to much. So, Rachel, the first half of that question was around engaging men in the interventions. Can you talk to that?
Yep, I always get this question. It's usually the first one. So we chose to focus on women because we were focusing on a workplace that is extremely dominated by women. So upwards of 60% is the floor of women in garment factories, and in many cases they're as high as 80%. And I would say electronics factories are closer to the 80% number. So we chose women intentionally because they were the majority of our target beneficiaries. Also, to my point before about when you're gender neutral, you leave women out, I think in particular in a lot of the Asian countries where we began our work, we only recently expanded into Kenya. If we had started the program as men and women, even if they were trained separately, I don't think that the empowerment benefits would have been near as high because the women would have deferred to the men, basically. So I think targeting women first is a really good strategy for getting them involved and actually getting men interested in what's going on because they're not used to being left out of things. So we've had some successful second programs that work with men because the men are so frustrated that the women get something that they don't get, and so then they're more interested in going to health class. So we are working on integrating men. I would say our beneficiaries are primarily women still, but we're going to get some curriculum materials up that are male focused. We have done some programs in Pakistan in particular and China working with men. I would say the family planning context in Africa tends to be a little bit different, so we're learning that as we go, and we'll continue to evolve.
And the second half of that question was surrounding the dialogue between workers and management and how that process happened and how to engage leadership to change their policy and adapt their policies to be more appropriate.
Was it for Zafar or for me?
I think that was also in the context of the HER project, actually. Yeah, is that correct?
Yeah.
I'm in the hot seat. So the management employee engagement, I think, one of the really unique things about HER project is we often go in the context. We work with the multinational companies, so they sort of open the doors for us. And so a lot of times the factory management or the farm management is very kind of apprehensive about us being there, and they think that we're there to see if they're doing things right and that we're part of the compliance programs that multinational companies have. And so as we break that down, the length of our program I think is very important. It being a whole year instead of a month or 2 months or a one-time intervention. That goes towards building those relationships. And I think it's quite natural because as the women learn about health, they start talking about it. And one thing that's interesting is that the direct supervisors of a lot of these, the women line workers, aren't that different from them. They don't earn that much more. They don't know much more about health. And so they start to kind of realize that they share a lot more than they thought they did. And I think that starts to break down barriers. So something about the fact that our program is very health-focused allows people to connect to each other as people and starts to break down the really kind of artificial barriers that exist, particularly in the factory setting between authority and I don't know the word. Anyway, people under them. Can't find the word right now. Subordinates. I didn't really want to say that. It's sort of, yes. Anyway.
Thank you, Rachel. And there was a question here, the lady in front here.
Hi, Ilza Melgalis with the UN Foundation. I have a question about another level of return on investment, and this is not necessarily for making the business case to companies, but just might speak to an additional overall value of investing in health through the workplace. So one quick initial question to David. I remember when reviewing the HIM project benefits that not the HIM project, the HIM initiative benefits, which is a male workplace program, that the uptake of family planning services by the women in the lives of the men who went to the program increased by 30%. So there was a 30% increase in utilization of reproductive health services by the women in those men's lives. So is that correct, or am I misremembering? If it's correct, I'd like everyone to know that. And then the second question is, do any of you know of any data or studies that show a ripple effect, so that when you invest in, workplace, it's a captive audience. It's a great place to deliver healthcare services, and one would think that these people then go home to their communities, whether it's at night right where they live or when they go back home to where they're from, that then they spread these health messages, and it's potentially an incredibly efficient method of public health and behavior change. But is there evidence to that effect? Because if so, that's also powerful.
Thank you. So that's David.
On family planning, we weren't able to track partners' family planning uptake. What we did find is family planning did increase. It was a very complicated data collection because many places around the world, they have outages of supply and the company has to buy it, so it becomes very hard to track. But in the period we tracked, we saw maintenance and continuing use went up and family planning use went up. I should say, on gender, gender becomes code for women. But, not taking a neutral piece on gender isn't just about women. You also discover things about men, that their needs in ways, if you don't think about it and disaggregate it, you don't notice the ways that men have needs too that don't get addressed because it's all wrapped up in worker. And that obviously hides a lot of issues. I know there are a lot of things going on in terms of, outside of her project, looking at the cascade to the community. I know the International Center on Research for Women is looking at the relationship between community and workplaces. But I don't have any data on the top of my head to give you.
Yeah, and I will say that if anybody in this room wants to pay for their own study, we will make her project available to you to do that study, because we'd love to know that too. Anecdotally, we see it all the time. Absolutely, without question.
Hi, thank you. I'm Martha Brady from the Population Council. We actually work a lot in reproductive health and family planning. We probably do have some of the data I think that people might be interested in. But I wanted to thank you all because I thought the panel was great. I have 3 questions, or 1 for each. I think the first point about the return on investment, I like this return on opportunity, the lost opportunity cost sort of thing. And I think it's very important what you call the broader returns, the obliques, because I think that there's so much spin-off that we don't capture very well, that I think we have to figure out ways to measure those broader impacts that don't necessarily fit into an easy measurement scheme. So I'd like to maybe talk to you about methodology afterwards. Rachel, is it? Sorry? On her project, I think this is great work you're doing. I have a question about, one of the things we know is that knowledge is necessary but not sufficient in terms of behavior change, okay? So there's all sorts of peer education models, et cetera. So I think what I would call the dose response, sort of the level of exposure to that knowledge, that peer intervention seems to be really critical to me. And so I'm wondering whether you have data or you were able to get data on tracking some of those women over time, because I think that's what you want to have ultimately, to know that, if you're in a program for a year and how much exposure you have to that will help you get to know what that impact is. So that's whether you have that data. And then the last point, I think in the case of Bangladesh, again, thank you very much for that excellent presentation. And I think we all do agree that women want and need to work in factories all over the world and want to make them as safe as possible. I do like this model that you have with the TB model, and I think it's a great model. The question I would have is, that works for TB in Bangladesh, because that is actually an important disease burden country for that issue. So I think other countries would have to figure out what is the particular issue of most importance to that population in order to have a model that makes most sense there. And then lastly, about the male involvement, I always use this term called, we want to empower women and enlighten men sort of at the same time. So programs that can do that, I think, would be good. So I think that's all comment.
So Zafar, maybe you could talk a little bit about how the model that you've developed of the public-private partnership could be used in different settings, perhaps in a non-TB space.
Thank you very much for the question. I think that's what we are also promoting. I mean, two things we have learned, apart from the general lessons learned from the model, how we connect the services or we connect different services within a particular model. But what we developed from our experience, that there are some set of principles which you can apply to other health programs in order to make public and private providers to come together and to deliver a particular health services. So we used those principles, and then particularly around relationship making, breaking the barriers or perceived barriers between public sector and private sector perceptions. I mean, this public sector is good or bad, those kind of barriers. And then making more sort of joint planning and evaluation of the health program is also very important. So gaining trust and making the relationship is very important. Secondly, we suggest that you apply a systematic process to engage different components of the private sector, because they are complex and they have got different sort of objectives for health, because they want to get return from any investment, even if it is for health. So we need to recognize those objectives within the development of the model. So we do have those set principles and steps. We have published those. These are, I mean, the steps and principles are published, and also the actual project has been published in the BMJ last year. But finally, I mean, in terms of adopting the same model, we have started public-private partnership for family planning just recently. So, and I'm going to Bangladesh later this month to launch this project. So we are taking the same or similar model to engage the private sector in providing family planning or referring to the existing family planning services, so connecting them with the existing services. So we have done it for the sexually transmitted diseases, and now we are doing it for the, or we are starting to do for the family planning. So I hope it would work.
Maybe David could address one of the other parts there. Are there systems in place, or is there data coming in to track the longer term effects of these, particularly of the, you call them the spin-out effects, you know, the...
No, to quote Rachel, someone want to give some money to do that, that would be great. But let me, outside of the let's be an M&E and prove, sometimes we spend a lot of time proving the obvious. I know that is sort of anathema to say, but we have to prove again and again these things. Part of the point on this is I want to say to business, look, you really can look at these things in a different way. Not just about the good you're doing for workers, but how this really improves your entire approach to the workforce and management. I mean, we see in all these programs, how many of these countries people learn very didactic way of talking and learning, what goes from the top all the way down. We know from research across countries, this is a very ineffective way to do it. These programs like her project is all about non-didactic ways of training. So it's not just about doing it for the workers, it's also about how do you bring that into your entire workforce. It transforms the way management is done. So part of my piece here is stop thinking about this just about the good you're doing to workers, thinking about this, how this improves your whole business piece. On the male engagement, I just want to make one point that I think is really important. And people say this all the time, and no disrespect, as my son always says when he insults me. But we need to stop talking about male engagement. How do we get men to do more for the women and give up power? At Unilever, both in Kenya and Tanzania, the reality was that male engagement in equitable gender relationships empowers men. It's good for them. And men after men in Kenya, they would say things like, you know, I'm actually alone and I actually don't have the power because I don't have a lot of choices. I'm doing a very narrow set of choices, whereas I can now be a part of a discussion. And in fact, as we know about power, it's very lonely if you're the one that's only making decisions. It's far more powerful when you are sharing decisions and you have a set of relationships. So we need to think about how we talk about male engagement, not just about how it's good for women, but in fact, it's very good for men.
Thank you very much. Yep.
I'm Donna. I work with ALAFA. It's a project doing prevention programs as well as care and treatment for the workers in the apparel industry of Lesotho. So just 2 comments and then 1 request. Just to add to the comments about the obvious importance of engaging with male workers as well. We found something similar, you know, where we started engaging primarily with women, but then that opened up space very much to identify the needs specifically of the male workers. And I think, you know, it may be obvious, but it's important to remember that when we're talking about issues of sexual and reproductive health, nothing happens in the absence of people's partners, whether that's their husbands or partners or sexual partners. So I think that's also important. I think the search for data on some of the effects of these interventions can often be quite elusive. We recently did a study of the prevalence in the industry, but also the impacts of particularly the peer education programs that we're running. And some interesting data came out of the effects of people participating in peer education programming, but also the actual impacts of being trained and active as a peer educator, which we think are very encouraging and are sort of across the industry. We'd be very happy to share that information with anyone that would like to look at it. And David, just a quick request from you. You had mentioned the Better Together report. I'm sure some of us would be quite interested in having a look at that if you might make that available.
I'm sorry, say it again, just someone coughed and I missed what you said.
Oh, sorry, the Better Together report that you mentioned.
Yeah, I'd be happy to send it. It's core group. If you do the core group in DC, it's on their website, Better Together. But I'm also happy after if you give me your card, I can email it to you as a PDF. So.
Hi, I'm Louise from UNFPA, and we have an obvious interest in trying to promote family planning services and sexual and reproductive health services in the workplace. Just to really ask, well, any of the panel, but maybe Rachel in particular, whether you received any negative kind of feedback from workers around family planning in terms of if it was a provision by the employer, whether there was any kind of feeling that, oh, my employer doesn't want me to get pregnant, this is why they're giving me family planning advice. You know, I mean, there's ways to kind of promote this in terms of lack of absenteeism, but I think there's also another dynamic, which is where you're trying to promote pro-family choices and pro-planning, but without, you know, inhibiting people's right to have children. So I just wanted to hear from that perspective whether you ever had any of that kind of feeling from the workforce of, well, I'm not going to take this service because I think it's all about trying to stop us having babies. So I just wanted to hear a little bit on that. Thank you.
Yeah, I think it's a wonderful point, and I'm glad that you raised it. It's something that I keep top of mind all the time when having these conversations, and it's a delicate balance between the sort of human rights, labor rights community and the public health community, particularly the family planning advocates. So I should say that we do not introduce products like family planning products into workplaces ourselves. It's happened through partnership with Mary Stopes International in Pakistan and the local government population office. But otherwise, if the workplace has the products already, then we are generating demand for them in a way that they weren't being demanded before. But we don't tend to introduce them. And just to also build on the question that came from over here, which is, I think, something very unique about particularly female factory workers in Asia, is that they tend to have access. They tend to have access to these products, and they tend to have a small amount of income that they can spend on themselves, and they can make the choice to spend it on themselves. So they're a unique population in that sense. Because they are in the urban environment and the particular countries in which we work, they're able to buy or get for free the family planning products pretty easily. So having them in the workplace isn't necessarily required. We haven't seen a lot of negative backlash, and I think that's largely because we do take an integrated, holistic approach, and by the time we get to family planning, the management and the workforce trust and respect the local organization that's delivering the program. And so a lot of these sensitive issues are dealt with in the normal way that human beings deal with them all the time, because we've built into the program the amount of time required to actually do those things correctly. So we haven't seen much negative backlash on that.
Thank you very much. Unfortunately, I'm being told there are 0 minutes left, so I know the panelists would be very happy to answer your questions over coffee or by email, so please don't be shy in coming forwards. So I hope you found that session useful, and it's inspired you to focus on the many women's health issues that you can address via your workplaces. Thank you to David Wofford, to Rachel Myers, and to Zafar Olaf for their participation, to Dr. Brian Brink and Anglo American for their sponsorship, and obviously to Joy Banerjee, who I think's escaped, and the GBC Health team for their excellent facilitation. Thank you very much.